the limitations of the currently available therapies like inotropes and bronchodepressors, the shortage of for MCS, mechanical circulatory support devices like Impel and others. So we will see بقى أبو العز يورينا البيبر اللي هي كانت published 2019 والحقيقة يعني very interesting paper which is summarizing everything about cardiogenic shock from etiology up to different managements. So we'll see Abou Elezz and we'll have a discussion after his presentation. Okay, Abou Elezz.
Good afternoon. I am Mohamed Abou Elezz, an assistant lecturer of cardiovascular medicine in Cairo University. And in today's journal club, we will be discussing the management of cardiogenic shock, complicating myocardial infarction, according to the position paper released by the ESC in 2019. The presence of multiple different definitions of cardiogenic shock across different trials conducted on cardiogenic shock in acute myocardial infarction led to the ESC proposing a unified definition of cardiogenic shock to be used across all studies. This is composed of end organ hypoperfusion and hypoxia that is due to the presence of primary cardiac disease. Hypoperfusion in the form of persistent systolic blood pressure less than 90 millimeters of mercury that is not responding to volume replacement, as well as evidence of hypoperfusion that could be either clinical or laboratory evidence. Clinical, such as cold extremities, oliguria, or altered mental status, or laboratory findings such as elevated lactate, metabolic acidosis, or abnormal kidney or liver function tests. Objective assessment of hemodynamics using a cardiac index or the pulmonary capillary wedge pressure can assist in the diagnosis. However, this is not usually needed. Primary cardiac disease that could either be infarct related, which is our topic for today, or non-infarct related. Infarct related, up to 13% of acute myocardial infarction patients develop cardiogenic shock. The overwhelming majority of the cases, this is due to left ventricular failure. A small but very important subset that should not be missed is cardiogenic shock due to mechanical complications, whether acute severe MR or ventricular septal rupture or free wall rupture. Cardiogenic shock is a spectrum of multiple different patients and different presentations. It could range from patients who are not outright shocked, hemodynamically stable. However, they have a cardiac disease that puts them at risk of developing cardiogenic shock later on, all the way to the other end of the spectrum, patients in severe hemodynamic instability, not responding to any measures and experiencing multiple cardiac arrests. This wide difference in presentation has led the SCAI to propose a classification for the different forms of cardiogenic shock. This allows for standardization across studies and better comparison across studies, as well as improve the management that is targeted to every stage of every different stage, as well as highlight the under-investigated pre-shock stage. Different stages include A, B, C, D, and E. Primary cardiac disease has to be present, of course, this is part of the definition. In the first stage, stage A, this is a hemodynamically stable patient with no evidence of hypotension or hypoperfusion. However, this patient has a severe primary cardiac disease that puts them especially at risk of developing cardiogenic shock. For example, patients with extensive anterior or anterior myocardial infarctions, anterior STEMI. These patients are more likely than their counterparts to develop cardiogenic shock later on. The second stage is stage B. This is termed the beginning of cardiogenic shock. These patients begin to develop hypotension or tachycardia or both. However, there are no outright evidence of hypoperfusion, whether clinical or laboratory. This is the beginning of cardiogenic shock. The third stage is the development of the full-blown picture of classical shock. This includes hypotension, tachycardia, as well as clinical and laboratory evidence of hypoperfusion. In this stage of shock, the patient is still responsive to pharmacological circulatory supports, to inotropes and vasopressors or fluid loading. Hypoperfusion improves on these measures. The fourth stage, this is doom. This is stage D. It is similar to stage C. However, the patients stop responding or do not respond to circulatory supports. And finally, the terminal stage is stage E, extremis. These are patients, we encounter those patients a lot in the CCU, that are severely hemodynamically unstable, experiencing multiple cardiac arrests with return of spontaneous circulation on CPR, and then the patient's arrest again, and so on. Or patients on veno-arterial ECMO. This is one form of mechanical circulatory support. The pathophysiology of the different stages of cardiogenic shock is very complex. I will not delve into extreme detail. I will just skim over the pathophysiological differences between each stage to highlight the stages further. Stage A, the cardiac index is normal. The hemodynamics are normal. This is not a shocked patient. He's just having a primary cardiac disease that puts him at risk of developing shock later on. As the patient progresses into stage B, the cardiac index starts to drop, and therefore the systolic blood pressure starts to drop as well. As a compensatory mechanism, systemic vasoconstriction develops. This increases the systemic vascular resistance, and this helps maintain the systolic blood pressure as well as maintain peripheral perfusion. The pulse pressure obviously decreases because the systolic blood pressure remains the same. However, the diastolic blood pressure increases due to the increase in systemic vascular resistance. Progressing into stage C, there is an overwhelming decrease in cardiac output and cardiac index that overwhelms even the compensatory mechanisms of the body, that overwhelms the vasoconstriction. So the blood pressure finally starts to drop. In addition, the systemic hypoperfusion and the accumulation of different metabolites in the capillary beds causes eventual and gradual vasodilation of the arterioles and the venules. This causes capillary stasis and stasis of the blood in the capillary beds. With further accumulation of metabolites and progressing into stage D, these metabolites start to cause paralytic vasodilation of the arterioles and the venules, with massive stasis in the capillary beds and increased capillary permeability, causing leakage of blood, leakage of fluid, into the capillary beds, and an overall decrease in the circulatory volume, further accentuating the drop in blood pressure. Finally, in stage E, there is tissue loss, myocardial loss, excessive acidosis, and accumulation of metabolites, and the circulatory volume is very low due to the large capacity of the capillary beds after the paralytic vasodilation. And this is usually an irreversible stage. As is with all different diseases, risk stratification is important to highlight patients that are in need of extra care or extra attention and are more likely and are exposed to higher mortality. Currently, according to the position paper in 2019, only 2 scores have been externally validated and are recommended for use by the paper. The ORBI score, this is used in STEMI patients in stages A and B of shock, and the IABP shock 2 score that is used in stages C, D, and E of shock. This excludes patients on ECMO. ECMO has its own scores, and none of the scores have been validated yet. The ORBI score has patient-related factors such as age and TIA or stroke history, the patient's clinical picture on presentation, heart rate, blood pressure, random blood sugar, presence of cardiac arrest on admission or KILIP class, and angiography and infarction-related factors such as the presence of anterior STEMI, a left main culprit, the delay to primary PCI being more than 90 minutes, or the TIMI flow post-PCI. As for the IABP shock 2 score, it is a simpler score. that also has patient-related factors such as age and stroke history, laboratory values of random blood sugar, lactate, and creatinine, and TIMI flow post-PCI. There are 5 pillars of management of patients' cardiogenic shock due to acute myocardial infarction. There is the diagnosis and risk stratification, the management of acute myocardial infarction that includes emergency revascularization, restoring end organ perfusion, general ICU supportive measures, and the consideration and the use of mechanical circulatory support. In general, management begins as early as possible. Early diagnosis and treatment are the key. It begins even in the pre-hospital stage. This is before the patient presents to the emergency room. For example, in the ambulance. Obviously, cardiogenic shock is a complex disorder with a high mortality that requires management in a tertiary center that has to be high volume and great expertise, and it should be properly equipped with the necessary device. The diagnosis and risk stratification of cardiogenic shock due to acute myocardial infarction involves proving the presence of acute ischemia, which is through combining clinical and ECG findings. ECG should be performed within 10 minutes, and the use of troponins if needed if the ECG does not display STEMI. Vitals and evidence of hypoperfusion, as mentioned before. The volume status must be assessed as well on first presentation, and immediate echocardiography by a trained physician. This is very important. Even a rapid focus study in the emergency room should be conducted. And this should target assessment of the systolic function of both ventricles, the presence of mechanical complications or pericardial effusion, and the volume status of the patient, whether through assessment of the IVC or the diameters of the ventricles, or the VTI and the LVOT, variation with inspiration and passive leg raise, and lung B lines, as well as exclude potential differential diagnoses. Later on in the CCU, a full comprehensive study should be done. The management of acute myocardial infarction. Revascularization is the cornerstone of management of cardiogenic shock due to acute myocardial infarction. The as early as possible. The timing should be performed in an emergent form in STEMI and non-STEMI patients. And this is regardless of time since symptom onset. This is in contrast with the regular management of STEMI patients. The SHOCK trial has demonstrated the value of early revascularization by improving mortality at 6 months, 1 year, and 12-year follow-up versus initial medical stabilization. PCI is the standard procedure. There is no difference between PCI and CABG in outcome, and therefore PCI is the standard procedure. Coronary artery bypass graft should be used if PCI fails, or the vessels are not amenable to PCI, or if surgery is planned anyways for mechanical complications. As per the standard guidelines, radial access is preferred, although the evidence is weaker in cardiogenic shock patients than in non-cardiogenic shock patients. Radial access has lower mortality and less likelihood of complications compared to the femoral access. The radial access presents an additional advantage in patients with cardiogenic shock due to acute myocardial infarction by sparing the groin area for the use of mechanical circulatory supports. However, the radial access in shocked patients is extra challenging. And the reasoning for this is that the pulse is usually not quite palpable and may not be palpable at all. Up to 80% of the patients have multi-vessel disease on coronary angiography. And this is a poor prognostic finding. The culprit shock trial has demonstrated the benefit of culprit-only revascularization during index procedure, showing lower mortality and lower need for renal replacement therapy. This is in contrast with previous guidelines that advocated for the complete revascularization in shocked patients on presentation. Staged revascularization can be done later on during hospital admission for the remaining lesions. There is no evidence supporting fibrinolysis in cardiogenic shock due to acute myocardial infarction. Expert recommendation concluded that in the case where early revascularization through PCI is not feasible, we can use fibrinolytic therapy. The choice of antithrombotics in shocked patients is especially complex. The reason for this is that these patients have impaired absorption due to hypoperfusion, due to opiate use, due to the need to crush tablets into the nasogastric tube in mechanically ventilated patients, or due to the use of therapeutic or targeted temperature management in arrested patients. All of these factors impair absorption. There is also impaired hepatic activation of clopidogrel. Clopidogrel is a drug that needs activation before being active, before producing its effects, its pharmacological effects. This obviously decreased due to hepatic hypoperfusion. There's also the need for reversibility in patients who are scheduled for surgery. For example, if the patient has a mechanical complication, we have to use agents that are rapidly reversible. Here, the potential for IV cangrelor, this is a new IV P2Y12 inhibitor, arises. Cangrelor, being IV, has 100% bioavailability. It also has a rapid onset and a rapid offset of action, and it is especially advocated for in the presence of heavy thrombotic burden. Currently, there is the DAPT shock AMI trial being conducted comparing cangrelor to ticagrelor in cardiogenic shock patients. For anticoagulation, the current recommendations are as per the standard guidelines. However, the go-to agent is usually unfractionated heparin for two reasons. These patients usually present with concomitant AKI, acute kidney injury. And the second thing is that these patients are at an increased risk of bleeding, especially if mechanical circulatory supports are being used. So the rapid reversibility of unfractionated heparin is a plus. As for group 2B, 3A inhibitors, as per the standard guidelines, these are not indicated routinely. They should be used only in the presence of heavy thrombotic burden. In case of development of mechanical complications, these patients have very poor prognosis. This should follow a heart team decision. These patients are complex, with each patient being different than other patients, with no major trials being conducted on these patients. So the general recommendation is that it should be a heart team decision. In patients with acute severe mitral regurgitation, mitral valve replacement, class 1C, is usually the recommendation. Repair is very difficult in these patients due to the presence of friable tissues in the acute stage. Ventricular septal rupture presents the timeless dilemma of early versus late closure. Early closure allows for the stabilization of hemodynamics early on. However, it has an increased risk of VSD extension into the free wall or reopening of the VSD later on. And this is all due to the friability of tissues in the acute stage. Late closure allows for better and more secure closure of the VSD, of the ventricular septal rupture. However, it exposes, sometimes this is not the best choice. The patients are usually compromised, extremely compromised, and they need early closure to maintain hemodynamics. And this is where mechanical circulatory supports, such as the intra-aortic balloon pulsation, could buy us some time. They could stabilize the hemodynamics and allow the surgeons enough time for the ventricular septal rupture edges to fibrose and for the repair to be more secure. Finally, free wall rupture is a critical complication that requires emergency percardiocentesis and surgery. The third pillar is the maintenance of perfusion, of end organ perfusion. As is the case with a management of acute myocardial infarction, this begins in the pre-hospital phase, in the ambulance if possible, and in the emergency department. The target is to maintain a systolic blood pressure of more than 90 millimeters of mercury, or a mean blood pressure of 60 to 65, not more, 60 to 65 millimeters of mercury. The first measure that should be done in shocked patients, if there is no overt fluid overload, is giving a fluid challenge. This is even in euvolemic patients. And the reasoning behind this is that a small amount of volume can increase the stroke volume and the cardiac output and improve the hemodynamics in euvolemic patients. 250 milliliters of isotonic saline or lactated ringer should be given over 15 to 30 minutes, and this should be guided by the echo parameters of volume assessment. Extra care should be taken in patients with RV dysfunction. In patients with RV dysfunction, the therapeutic margin of fluid resuscitation is very narrow. Fluids are beneficial as they increase the preload and support the right ventricle. However, excess fluids, even slightly excess fluids, can cause RV distension, and this compresses the left ventricle and impairs left ventricular filling. And therefore, these patients should be taken care of. Pharmacological circulatory supports. 90% of all cardiogenic shock patients will eventually require some form of pharmacological circulatory support. This could either be a vasopressor or an inotrope. Unfortunately, these agents, as potent as they are double-edged swords. They increase myocardial oxygen consumption, they increase the afterload, and impair coronary microcirculation. And therefore, the recommendation by the ESC is that they should be used in the lowest possible doses for the shortest possible duration. Number one, vasopressors. Norepinephrine is the drug of choice, class 2B. Other agents, unfortunately, are associated with worse outcomes or complications, or they were not investigated appropriately. The Optima CC trial has compared the epinephrine to norepinephrine and demonstrated that patients on epinephrine develop refractory shock more often and greater levels of lactic acidosis. Dopamine is associated with the higher incidence of arrhythmias compared to norepinephrine. Finally, vasopressin and phenylephrine were not investigated enough in cardiogenic shock patients, and therefore no recommendation regarding their use could be given. Number two, inotropes. Dobutamine is the agent of choice and should be administered, or usually is administered, with norepinephrine. Levosimendan, in the specific subset of acute myocardial infarction, has shown no benefit over the administration of dobutamine. And the OPTIME CHF trial has demonstrated a higher mortality in patients with cardiogenic shock due to ischemic etiology with the use of milrinone. Monitoring cardiogenic shock, as we mentioned, our patients with this disorder are very critical with high mortality and poor prognosis, and therefore very close monitoring should be done for these patients. Vitals and saturation should be monitored every 30 minutes. Evidence of clinical hypoperfusion should be monitored every 4 to 6 hours. An arterial line and a central venous line should be inserted in all shocked patients. The value of arterial line in these patients is that it allows for invasive blood pressure monitoring, as well as allows for the analysis of the arterial waveform, which may reveal additional data, for example, volume depletion, and it allows for the withdrawal of regular arterial blood gases, especially in mechanically ventilated patients. The central venous line in these patients also has value. It allows for the measurement of the central venous pressure. It provides an adequate access for vasopressors, as well as allows the monitoring of the mixed venous oxygen saturation, which allows for rough assessment of the cardiac output. Urinary catheter should be inserted in all oliguric patients. Pulmonary artery catheter should not be used routinely, as evidenced by the ESCAPE trial. They should be used in specific scenarios where there is no response to treatment or the diagnosis is uncertain. The patient, for example, we are giving various measures to support the circulation and there is no improvement or partial improvement, or when there is suspicion that there is significant RV dysfunction. In these cases, the pulmonary artery pulsatility index is a good value to assess for RV dysfunction. This is the pulmonary artery pulse pressure divided by the right atrial pressure. Values less than 1 signify the presence of RV dysfunction. ECG, chest X-ray, and echocardiography should all be done in all patients, with continuous ECG monitoring mandatory in all patients, and echocardiography and X-ray should be repeated as warranted clinically. Lactate and lactate clearance should be monitored every 6 hours, every 4 to 6 hours. Routine labs in the form of CBC, routine chemistry, and coagulation profile should be withdrawn on a daily basis, and cardiac biomarkers, depending on the agent being tested, should be withdrawn in a serial manner. Oxygen saturation in the arteries should be maintained at over 92%, preferably using non-invasive measures. However, 60 to 80% of these patients will eventually require invasive ventilation. If this becomes the case, lung protective protocol in the form of 6 milliliter per kg predicted body weight tidal volume should be used. Renal replacement therapy should follow the standard indications as in any other patients. 1/3 of all cardiogenic shock patients will develop AKI, with a further 14% will eventually require renal replacement therapy. However, this is usually transient. Kidney functions usually recover or improve with the recovery from cardiogenic shock. Early renal replacement therapy before the presence of any of the frank indications of renal replacement therapy has demonstrated, studies on this case has demonstrated the presence of no benefit, and therefore the recommendations are to just perform renal replacement therapy following the standard indications. Intermittent hemodialysis is usually not feasible in these patients due to the severe or significant hemodynamic instability they have, and therefore the recommendation is to use continuous veno-venous hemodiafiltration. Blood glucose should be maintained between 144 to 180 milligrams per deciliter. Early enteral feeding, concerning nutrition, early enteral feeding in these patients was associated with more GI complications, and therefore the general recommendation is to not give any feeding, any nutrition enterally in the early phase, with potential introduction and gradual introduction of parenteral nutrition later on. Targeted temperature management should be used as per the general guidelines in post-arrest patients, with no evidence in the shock-cool trial of benefit of targeted temperature management, that is hypothermia, in non-arrested patients or patients with no previous cardiac arrest. It even increases the lactate levels in these patients. Bleeding is a common problem encountered in cardiogenic shock, especially with the use of mechanical circulatory supports or anticoagulation. Transfusion is only indicated in a restrictive form at hemoglobin level less than 7 grams per deciliter, unless obviously there's an obvious or massive clinical bleeding, and in this case, we can disregard this rule. Gastroprotection and thromboprophylaxis should be conducted as indicated in other cases. Finally, mechanical circulatory support. These devices are promising in cardiogenic shock, with their ability to improve hemodynamics beyond the abilities of pharmacological agents. However, they are held down or held back through limited randomized control or solid data on their use. Advocates of mechanical circulatory supports or supporters of the use of mechanical circulatory support argue that the success of these devices depends on 3 factors: proper patient selection, proper device selection, and the prevention and management of their complications. First of all, proper patient selection. If we look at all cardiogenic shock patients due to acute myocardial infarction, 50% of those patients will survive anyway, will survive without the use of mechanical circulatory supports. In this cohort, if we do use mechanical circulatory support, we will not modify their course, the course of their disease, because they will survive anyway. They will survive even if we don't use mechanical circulatory support. However, we are exposing them to the myriad of complications that are brought upon them by the use of mechanical circulatory supports. And therefore, we are effectively decreasing their chances of survival. In the other 50% of patients with cardiogenic shock complicating infarction, 30% of these will die anyway. They will die whether we do use mechanical circulatory supports or we don't use mechanical circulatory supports. That is, mechanical circulatory support use will not modify the course of their disease. And this is usually due to the presence of severe comorbidities, for example, severe uncontrolled sepsis or severe neurological impairment. And therefore, mechanical circulatory support use in these patients is not recommended. Or they can be used just as a bridge to decision if the doctors still have to consult with the relatives to decide on the best course of action for this patient. The remaining 20%, cohort B in this diagram, these are the target of mechanical circulatory support. You see, these are the patients that we should target with mechanical circulatory supports. These are patients who would have died without the use of mechanical circulatory supports. However, the course of their disease has been modified through the use of mechanical circulatory support. That is, we gave them a chance of survival through the use of mechanical circulatory supports, and without them, they would have died. Now, selecting patients in these cohorts depends on the following factors: the age of the patients, the younger the better, the neurological status of the patients. For example, a patient that is post-arrest and with multiple CPRs, with poor neurological function, these patients, mechanical circulatory support will be futile. But patients with better neurological status, for example, post-arrest patients or patients with good neurological function, these are better candidates for the use of mechanical circulatory supports. The presence and the severity of comorbidities should also be factored in this decision, and the stage of cardiogenic shock should also be factored in this decision. The current recommendation by the paper is that mechanical circulatory support should be used in refractory cardiogenic shock not responding to pharmacological measures. However, some people do advocate the use of early mechanical circulatory supports, the milder forms, that is, the forms with less complications, very early on. For example, there are some people who advocate the use of the Impella device, we will describe it later, during revascularization in the very first stage of management of cardiogenic shock due to acute myocardial infarction. However, the evidence is scarce. Then we get to the device selection, selecting the appropriate device or the appropriate mechanical circulatory support for the patients. Currently, there are 4 temporary percutaneous mechanical circulatory support devices available. The intra-aortic balloon pulsations, this is basically a balloon that is inserted through the femoral artery and placed in the descending aorta below the subclavian artery, the left subclavian artery. This balloon inflates in diastole. This allows for the forward flow of blood during diastole and deflates in systole, causing a region of relatively low pressure and decreasing the afterload on the ventricle, allowing better pumping of blood during systole. The Impella device is effectively a turbine. It is a turbine that is inserted through the femoral artery in left-sided cases and the turbine itself is impacted into the aortic valve. This turbine works by withdrawing blood from the left ventricle and pumping it back into the aorta, therefore enhancing the systolic function of the ventricle. There is a right-sided form of this device. It's called the Impella RP, and this is inserted through the femoral vein and ascended in the inferior vena cava, impacted into the pulmonary artery or the pulmonary valve. Tandem heart is a paracorporeal device. That is, the device itself is outside of the body. It is adjacent to the body rather than inside it, as with the previous two examples. And it has two cannulas, the venous cannula and the arterial cannula. The venous cannula is inserted in the femoral vein and is placed through a transseptal puncture into the left atrium. And the arterial cannula is placed through the femoral artery into the aorta. The idea behind this device is that it withdraws blood from the left atrium, bypassing the ventricle entirely and pumping this blood back into the aorta. Of course, there is also a right-sided form of this device that is inserted through the right internal jugular vein, and it pumps blood from the right atrium into the pulmonary artery. Finally, veno-arterial ECMO. This is an extracorporeal device. It is a bulky device that is placed beside the patient. The device itself, again, is outside of the patient's body. And again, it has two cannulas. The venous cannula is inserted into the femoral vein, and the arterial cannula is inserted into the femoral artery. Now, the arterial cannula can either be left in the femoral artery, or it could be surgically placed into the aorta itself. Without going into too much details, this was a brief overview on the available temporary percutaneous mechanical circulatory support devices. All of these devices can usually be placed up to 3 to 4 weeks in the patient. However, some of these devices provide partial support. That is, they provide a fraction of the cardiac output, of the normal cardiac output of the patients, and other devices provide complete support to the ventricle. The intra-aortic balloon pulsations. بصوا تحت عشان انا بس البوينتر انا مش عارف ان انا اجيبه. لحظه. The intra-aortic balloon pulsations, or the balloon in short, provides partial support, only 0.5 to 1 liter per minute of the patient's total cardiac output of 5 liters per minute. And it only supports the left ventricle. The Impella device provides either partial support, 2.5 liters per minute of cardiac output, up to full support of the ventricle, up to 5 liters per minute of cardiac output. And this depends on the model. There are models that provide partial support, and more bulky models that provide full support. And it supports either the left ventricle only or the right ventricle only, depending on whether it is left-sided or right-sided. Tandem heart provides partial support for the ventricle, 2 to 4 liters per minute of cardiac output. And again, it either supports the left ventricle or the right ventricle, depending on the device and its placement. Finally, veno-arterial ECMO is the strongest device of them all. It provides up to 7 liters per minute of cardiac output, even in patients with complete cardiac arrest. It can be used during CPR and provides the full cardiac output and oxygenation for the patients. And it supports both ventricles at the same time. However, the right ventricular support is usually more than the left ventricular support. Now, selecting the device depends on the hemodynamic effects or the hemodynamic benefits of each device and the contraindications or the potential complications of each device. The balloon decreases the afterload by a mechanism we have described, by collapsing during systole and causing a negative pressure area during systole in the aorta that decreases the afterload. Another effect, very important effect for the intra-aortic balloon pulsations, is that it improves the coronary and cerebral flow. The Impella device also decreases the afterload through direct withdrawal of blood from the left ventricle into the aorta. This direct effect decreases the afterload during systole. It also improves coronary flow due to its position. The tandem heart device, it decreases the preload since it withdraws blood from the left atrium or the right atrium. It decreases the preload. And because it pumps this blood directly into the aorta and bypasses the left ventricle, it increases the afterload. The afterload during systole, more blood is present in the aorta during systole, and this increases the afterload. The same could be said for the veno-arterial ECMO. It decreases the preload and increases the afterload, especially if the cannula is placed peripherally. This is due to the difference in compliance between the peripheral artery, the femoral artery, and the aorta. So if the cannula is placed peripherally and not in the aorta, the afterload will increase dramatically, and this will attenuate the offloading benefit of this device on the left ventricle. However, ECMO is the only device which provides gaseous exchange, oxygenation, that is. The intra-aortic balloon pulsations is dependent on the presence of good quality ECG. Since it is ECG dependent, it acts in a pulsatile manner, and therefore it is dependent on the pulse. The other devices provide continuous flow, and therefore they are independent of the pulse and the ECG. The balloon is the easiest to insert and may not even require the cath lab. Impella is easy, not as easy as the balloon, but still easy, but requires the cath lab. Tandem heart is the most complex device of them all in insertion, requiring a transseptal puncture. And finally, the ECMO is easy to insert and does not require the cath lab if the cannula is going to be placed peripherally in the femoral artery. Being intracorporeal devices, that is, the device itself is placed inside the patient and is small, the devices are small, the artificial surface in the balloon and the Impella devices are minimal. How it is larger in the tandem heart, being a bulky device that is placed outside of the patient, and of course, it is the largest in veno-arterial ECMO, with the largest thromboembolic incidence of thromboembolic complications. Contraindications against their use. The balloon will increase aortic incompetence by inflating in diastole. It will cause the backward pumping of blood in the aorta into the ventricle in significant aortic incompetence. It should not be used in severe aortopathies, and if the patient has marked tachyarrhythmias, the device will not be able to properly synchronize with the ECG, and therefore their effectiveness will decrease. The Impella device is impacted in the aortic valve, as we mentioned. So it should not be used in patients with severe aortic stenosis or patients with aortic valve replacement. It should also not be used in the presence of LV thrombus, as it will dislodge the thrombus. It should not be used in the presence of a VSD, as it decreases the left ventricular pressure. And it should not be used in the presence of significant peripheral arterial disease. The tandem heart pumps the blood into the aorta from the left atrium, and therefore it increases the afterload, and therefore it will increase the aortic incompetence if it is present, as well as aortic dissection. Should not also be used in the presence of VSD, significant peripheral arterial disease, or contraindications to full anticoagulation. As we mentioned before, the artificial surface is large in tandem heart, and these patients should be on anticoagulation. So patients with contraindications to anticoagulation should not be using tandem heart. The same could be said for the veno-arterial ECMO, severe aortic incompetence, aortic dissection, and contraindications to anticoagulation. Evidence supporting mechanical circulatory support is scarce. That is high quality evidence. I mean high quality evidence in the form of randomized controlled trials. However, in all the evidence present supporting mechanical circulatory support use, the most consistent device showing consistent benefit is the veno-arterial ECMO. In multiple meta-analyses, there was a significant mortality benefit and a significant improvement in hemodynamics, even in patients with cardiac arrest or without cardiac arrest. In all patients, there was significant mortality benefit. This is in comparison to the intra-aortic balloon pulsations. Unfortunately, the other devices have no significant mortality benefit. Their use is usually advocated by the guidelines in the presence of mechanical complications, and they should not be used routinely. As we mentioned, the final point that supports the beneficial use of mechanical circulatory support is that we have to be on the lookout for its complications and rapidly manage them. These complications include bleeding, hemolysis and thrombocytopenia through the breakdown of blood cells, limb ischemia, thromboembolism, or failure of the unsupported ventricle. For example, in patients with severe RV dysfunction, the insertion of mechanical circulatory support that supports the LV can precipitate severe right ventricular failure. And this can be avoided through the use of biventricular support devices or devices that support both sides, either in combination or a single support device such as the ECMO. There are two complications that are specific for ECMO use. If the patient uses an ECMO device with a peripherally inserted cannula, this, as we mentioned before, severely increases the afterload on the ventricle. And this causes left ventricular distension if the ventricle is severely impaired. In patients with severely depressed LV function, this can cause LV distension, with subsequent pulmonary congestion and impairment of myocardial recovery, which is actually counterintuitive in patients with mechanical circulatory support. We are bridging them to recovery, one of the options. In this case, we can use intra-aortic balloon pulsations or impella to decrease the afterload. This is in conjunction with the ECMO. That is, we are using both devices at the same time. Or we can decompress the distended ventricle through the use of atrial septostomy. Finally, Harlequin syndrome can happen in ECMO, and this happens when lung recovery, when cardiac recovery precedes lung recovery. That is, the heart starts to recover faster than the lung does. In this case, deoxygenated blood that is returning from the still diseased lung enters the left atrium and is pumped by the recovering left ventricle into the aorta. This causes cyanosis of the upper half of the body. The lower half is not affected. This is due to the peripheral cannulation of the ECMO that provides oxygenated blood and decreases the amount of deoxygenated blood in the lower half. And this is solved through the use of different cannulation configurations. This is a summary from the guidelines from the position paper that is released in 2019, I am sorry. They are listing it as a list here. I tried to subdivide it into more organized form. The pillars we talked about, the diagnosis, as we mentioned, clinical, ECG, troponins if needed, evidence of hypotension and hypoperfusion, the volume status, early echocardiography, and proper risk assessment. The management of acute myocardial infarction and maintenance of perfusion, they should be executed as early as possible, even in the pre-hospital phase. Early revascularization is the cornerstone of the whole management through a radial access, PCI with drug-eluting stent as much as possible, culprit only in multivessel disease patients during the index procedure. IV cangrelor and unfractionated heparin are preferred over the other agents, and the management of mechanical complications should be guided by the heart team decision and the use of mechanical circulatory supports. Perfusion should be maintained through early restoration of perfusion. The target is systolic blood pressure over 90 or mean blood pressure 60 to 65. Fluid challenge if not volume overloaded, even in evolemic patients. Norepinephrine plus or minus dobutamine should be used in the lowest doses, shortest duration. General ICU measures, oxygenation, saturation over 92% through the use of non-invasive ventilation as much as possible. If invasive ventilation is used, a lung protective protocol of 6 milliliter per kg tidal volume should be used. Renal replacement therapy should follow the standard indications. Glucose level between 144 to 180. Nutrition, no early nutrition. Then parenteral nutrition should be introduced. Targeted temperature management to post-arrest patients only. Blood transfusion only if hemoglobin drops below 7 or there's an overt clinical problem. Gastroprotection and thromboprophylaxis as per the standard guidelines. Mechanical circulatory support use only in the proper patient that should be young, with good neurological function, controlled comorbidities, proper device selection depending on the hemodynamics of this specific patient and the contraindications and potential complications, and be on the lookout and manage complications that may arise as early as possible. Thank you.
شكرا يا أبو العز على المحاضرة الرائعة دي. حقيقة يعني you did a great job. محاضرة متحضرة كويس ويعني comprehensive and you covered everything in cardiogenic shock. يعني congratulations for this excellent presentation.
شكرا.
طبعا you mentioned طبعا how to approach, how to diagnose, how to manage risk stratification, everything in details. دايما في الكارديوجينيك شوك بيبقى في treatment goals. الجولز في الاكيوت ستيج طبعا mortality دوتهم من الاريثمياس، من pump failure، من mechanical complications. if they started to be supported ممكن mortality في السب acute phase بيموتوا من multi organ failure due to hypoperfusion. And if they recovered completely later on, mortality is due to heart failure. طبعا during treatment we have to protect other organs. We have to protect the brain, the lung, the kidney. So my first question, Abou Elezz, how to assess myocardial recovery in patients treated for cardiogenic shock?
Assessment of myocardial recovery is multifactorial. It should be this should be either through clinical improvement or improvement in the laboratory values or improvement in echocardiography and imaging. Clinical factors, obviously, the gradual resolution and of the state of hypotension on hypoperfusion, that is cardiogenic shock, and decreasing doses of pharmacological circulatory support if used. As well, if the patient is congested, the resolution of congestion also heralds or marks the improvement in myocardial function. The second item is the improvement in the laboratory values, and this includes whether improvement in the lactate, improvement in the organ functions. Obviously, cardiac enzymes, there should not be re-elevation or changes, ischemic changes in the ECG. Then there's imaging factors such as, for example, echocardiography. Routine assessment of the ejection fraction should be performed in these patients. It's very important at 0 hour on admission and at 12 hours after beginning management strategies, and of course on discharge from the CCU or discharge from the hospital, and comparing the ejection fraction as well as the regional motion abnormalities, the changes that occur before and after revascularization. Other factors, such as, for example, the patient's symptoms, the patient's functional capacity. For example, when he is discharged from the CCU, the patient could feel that his symptoms have improved and even resolved completely, whether it is ischemia or dyspnea, for example, due to the associated congestion if it is present.
طبعا الكارديوجينيك شوك في different phenotypes. يعني every patient has certain hemodynamic parameters, والmost complex form اللي هو cold and wet type اللي هم عندهم very high wedge pressure وعندهم very low cardiac index، ودول بيبقى complex patients. The timing of MCS is very important before further deterioration. بره في سنترز في بيعملوا revascularization لعيان very critical patient with borderline blood pressure. They insert an impella when dealing with a complex anatomy like left main. So early support with MCS in some patients is very important to avoid further deterioration and mortality. الحقيقه انت you didn't mention very important point اللي هي الشوك تيم. الشوك تيم دول بيبقوا well trained وفي طبعا يعني بره برضو لقوا ان الشوك تيم ده بيحسن الاوتكم اوف patients with cardiogenic shock. عندك ناس well trained عارفين how to manage patients presenting with cardiogenic shock. Did you know this term زي الهارت تيم شوك تيم، يعني ناس بتتعامل مع العيان cardiogenic shock؟
يا دكتور، هو فعلا زي ما حضرتك بتقول، هو بيكون في تيم يعني highly يعني qualified وعنده extensive experience in the management of these specific cases. وحتى في كمان MCS تيم مخصوص للميكانيكال سيركيلاتوري سبورت. هو ده بيخش في الستيج اللي هو البيشنت هيحتاج فيها ميكانيكال سيركيلاتوري سبورت، وممكن يكونوا موبايل كمان. يعني هم بيتحركوا بالميكانيكال سيركيلاتوري مثلا اكمو تيم او كده، وبيتحركوا للبيشنت، بيروحوا للبيشنت علشان يبروفايد يعني السيرفيس as early as possible و as efficiently و as expertly as possible.
صح. What is the role of hypothermia in cardiogenic shock?
Hypothermia, targeted temperature management in cardiogenic shock. حاليا البيبر بتقول ان هو تستخدم بس في البوست ارست بيشنتس، وان هو عموما دي following الستاندرد جايد لاينز في اي بيشنت بوست ارست، مش لازم يكون من الكارديوجينيك شوك. وهم لقوا ان التارجتد تمبريتشر مانجمنت دي لمده مثلا 48 ساعه دي بتimprove نيورولوجيكال ريكفري ان هو بوست ارست. الفكره ان غير البيشنتس اللي ما حصل لهمش كاردياك ارست، البيشنتس الكارديوجينيك شوك اللي ما حصل لهمش كاردياك ارست ايفنت، الشوك كول ترايل ادرست النقطه دي، اتكلمت في النقطه دي، ولقت ان هو ما فيش بنفيت عن الناس اللي ما خدتش تارجت التمبريتشر مانجمنت بالنسبه للمورتاليتي. بس لقوا ان البيشنتس اللي خدوا ثيرابيوتيك هايبوثيرميا او تارجت التمبريتشر مانجمنت وهم ما كانش حصل لهم ارست، اللاكتيت ليفلز فيهم كانت اعلى. يعني ما كانش ليها يعني اي سيجنيفيكانس على المورتاليتي، بس هم دي كانت فايندنج هم لقوها. فكانت البيبر بتقول ان هو بنستخدمها في البري ارست في البوست ارست بيشنتس بس، يعني ده على حسب علمي طبعا دكتور مجدي.
اوكي، اخر حاجه بقى هو طبعا احنا عارفين الهازاردز اوف انيوتروبس في العيانين دول، increase myocardial oxygen consumption و increase wall stress و precipitate arrhythmias. لكن في some trials على انها ورت benefit للليفوسايمندان as a superior inotrope compared to beta agonist او الفوسفوديستريز انزيم inhibitor زي الميلرينون، لانه طبعا معهوش الميتابول، معهوش other harm which can be induced with dobutamine and milrinone، لانه طبعا بيشتغل بميكانيزم مختلفه. what do you think about levosimendan?
هو
Do you know any trials
بتقول
which
هو في دكتور فعلا evidence على الليفوسيمندان في generally في الكارديوجينيك شوك، مش سبيسيفيك للبيشنتس اللي هم بوست اكيوت مايوكارديال انفاركشن. كارديوجينيك شوك يعني اوف اول كوزز هو في evidence فعلا ان الليفوسيمندان كان ليه superior او يعني ليه benefit في المورتاليتي بالمقارنه للبيتا اجونست زي الدوبيوتامين او الفوسفودايستريز انهبيتورز زي الميلرينون. وده بيرجع للإفكت بتاعه سواء على البريفرال فيسلز، ان هو الإفكت بتاعه على البريفرال فيسلز، او الإفكت بتاعه على اللونج فاسكوليتشر. الإفكت بتاعه برضه على اللونج فاسكوليتشر ده مش موجود مثلا في حاجه زي الدوبيوتامين. وطبعا الميتابوليك افكتس بتاعته ان هو مش كاتيكولامين، ده سبيسيفيك ان هو بيشتغل على الكالسيوم هيموستاسيس بتاع المايوكارديال سيلز. فهو من الاخر هو بيعمل بوزيتيف اينوتروبيك افكت من غير ما يكون ليه الاذر افكتس بقى ان هو اريثموجينيك او هكذا. فهو كان ليه بس في البيشنتس اللي هم كارديوجينيك شوك بسبب اكيوت مايوكارديال انفاركشن هو طبعا الايفيدنس مش قوي قوي، لان دي حاجه ما كانتش عليها الفوكس في الترايلز بتاعت الليفوسيمندان، بس الكورنت ايفيدنس يعني اللي هو اللي بيتقال كان في بيبر كده برضو اللي هو الهارت فيلير اسوشيشن بتاعه الاي اس سي، كانت طلعتها في 2020، كانت برضو بتتكلم على الكارديوجينيك شوك، بس كانت بتتكلم ان جنرال. اتكلمت عن نقطه الليفوسيمندان ان هو ليه بنفيت في البيشنتس ان جنرال، بس البيشنتس هم بسبب اكيوت مايكارديال انفاركشن ما كانش في سترونج ايفيدنس، او يعني ما كانش في جود كواليتي ايفيدنس ان فيفور او ضد اليوز اوف ليفوسيمندان بالمقارنه للدوبيوتامين. ده برضو يعني مش عارف هل انا كده مجمعها زي ما صح ولا
لا اوكي. you're right. اوكي ماشي. عندنا ساعة ونص، فأعتقد يعني الموضوع كان فعلا يستاهل الوقت ده في البرزنتيشن بتاعك اللي بحييك عليه وعلى الديسكشن كمان. شكرا جزيلا على المجهود، وبشكر طبعا الناس اللي حاضرة معانا، وأرجو إنهم يكونوا استفادوا من المحاضرة الممتازة اللي قدمها الدكتور محمد أبو العز. أشوفكم إن شاء الله في مرة تانية. شكرا، السلام عليكم.
شكرا يا دكتور. شكرا.